Thanks, Eva, for those very kind remarks. And kind of like last year was a little different in terms of being introduced, but it's the same thing. And I think up front, for me, what I really want to say is it's such an exciting pleasure to kind of see how this baby is growing and to really recognize that we've kind of, I think, come to an awareness that imaging, MRI and ultrasound are all very complementary and not one versus the other. And I think that's been one of the biggest battles that we've had to deal with when we started, is that we had opposing forces in the imaging arena. And looking around this room today, that's obviously not the case. So, this is a great meeting, and it's really just great and exciting to be here. It's very difficult for me to follow Mikhail not once but twice, and to try and give you a fresh look at what happens in clinical practice. And so some of this may overlap. Some of it, I think, is really related to the fact that, unlike Mikhail, who's surrounded by mermaids, I'm kind of like in the pits seeing patients on a regular basis and have to try and take whatever information I can get from the research environment, from the literature, and use it many times before. Unfortunately, it's become a sort of an acceptable mechanism of treatment or management for our patients with rheumatic diseases. And so part of the battle when you are in the forefront is you constantly feel like an icebreaker. You're breaking through the ice, and then there's another iceberg to get to. But I think we're getting there, and I think that this slide, which I've used a few times in terms of talking, is really still very, very illuminating in where we see that the great advances that have been made in the last 10, 15 years in the management of our patients, in increasing the ability to make a diagnosis and then ultimately recognize what the patient's presenting with is a disease that we should be managing, is really how this whole evolution is occurring. And now we've basically kind of, are desperately trying to catch up with the therapeutics, which are outrageously expensive, but which have made dramatic inroads into the treatment, and to try and figure out not only how to make a diagnosis, but what we spoke about or heard about earlier. The big challenge is when do we use these therapies? When do we determine if these therapies are not working? Because one of the biggest problems is that we start patients on these very, very expensive treatments and don't necessarily know for sure how they're working or if they're working. And then the flip side, as was mentioned, is when can we stop these treatments, which to me is probably the biggest challenge we've got in rheumatology. Because if I tell you I've been using biologic therapy on the same patient group since 1999, and I don't know, when I can stop in many of the cases. So I think those are very important, pertinent facts for someone who's in the daily practice. I also want to say that I think we kind of got ourselves boxed in the beginning by thinking that imaging was really focused on rheumatoid arthritis. And that caused a lot of problems because there was a lot of controversy as to the management of rheumatoid arthritis with and without imaging. And we kind of lost sight of the fact that as a rheumatologist, I would love to be a rheumatoidologist, but I'm not. I'm a rheumatologist who treats musculoskeletal disease across the board. And so we need to really understand that if you're thinking of putting an MRI in your office, or if you're just using it in general, it's really not just for inflammatory arthritis, which at best in most practices would amount to 40% at best. And yet, if you look at every other anatomical area in the body, we see that, in fact, from the neck to the ankle, there are multiple reasons why imaging is going to help you make a better diagnosis, a better choice of treatment, and develop a better outcome. Now, one of the problems we've had here in the US, and this is a very international meeting, which is great and which is what the society was meant to be, but it's kind of interesting to see how there's been a different support for imaging on either side of the pond, in the sense that the American College of Rheumatology has really not necessarily embraced it for us. And I put this slide in because one of the statements that they did make last year was that they came up with the 5 things that patients should question when their physicians order it. And one of the 5 was do not perform magnetic resonance imaging on the peripheral joints to routinely monitor inflammatory arthritis. And it's really an amazing statement, because I don't think more than 1% at best of rheumatologists could be accused of using MRI to follow inflammatory arthritis on a routine basis to monitor disease activity. Maybe they should, as we discussed, whether it's every 4 months or 6 months or 4 years, I don't know. But in terms of reality, to make that statement just threw more gasoline on the fire, so to speak. And as much as they basically, the ACR felt that they were in line with EULAR, in fact, last year in March, the EULAR published 10 recommendations, which I'm going to very rapidly go through, which I think should be the Bible, the 10 commandments, if you want, for the management of rheumatoid arthritis in your clinical practice. And so the recommendations, which I don't necessarily want to read through them because they're all in your book, but essentially, if there is a patient presenting with one or more joints, and there's a question of the diagnosis, when there's diagnostic doubt, certainly use standard X-ray if that's your baseline, but ultrasound and MRI can definitely be used to improve the certainty of the diagnosis of RA above clinical criteria alone. And when you compare it to clinical classification criteria, the demonstration of MRI synovitis increases the diagnosis of RA and was much more valuable than the presence of an anti-CCP antibody in the patient who is RA negative. So we definitely know that that happens to be the case. The second recommendation, the presence of inflammation seen with ultrasound or MRI can be used to predict the progression to clinical RA from undifferentiated. And we speak of the window of opportunity, and we speak of being able to basically make an early diagnosis. And you know what I should have said when I showed you the first connecting dots of the being aware of the diagnosis and treating early and then following the patient. The standard model that I think rheumatologists should be comfortable embracing is the exact same model that oncologists have embraced forever, that when you're treating a patient with a myeloproliferative disorder, lymphoma, you basically would use your imaging tools, whether it be a PET scan or MRI, to make a diagnosis and to follow whether your treatment is working or not. And so I've asked the question again and again, why should rheumatology or rheumatoid arthritis be a different disease? And the answer is, it really isn't. The third recommendation is detecting inflammation and damage, and ultrasound and MRI are superior to clinical examination in the detection of joint inflammation. These can be considered more accurate assessments of inflammation, obviously synovitis and edema being in particular what we're referring to, maybe more so than erosions helping diagnostically, but in many cases, a lot of the patients who've had possibly long-term rheumatoid arthritis may have erosions, and it's really not enough to just look at an erosion when you're managing your patient. The fourth recommendations is that standard X-ray of the hand and feet should be used as the initial imaging technique to detect damage. However, after that, one should consider ultrasound or MRI, because this basically will show damage at a much earlier time point, in particular in those patients who have a negative X-ray. Prognostically, very, very important, and Mikkel spoke about it, and we didn't compare our slides before we submitted them, so I'm not going to really talk about bone edema, which Mikkel did so eloquently early this morning, but it is a significantly important prognosticator. Probably the most important thing that we can use in our practice is to really have that as a guide to how severe the inflammation is, when we should be treating, when in fact we can stop treating. The recommendation 6, the inflammation seen on imaging is probably more predictive of a therapeutic response than clinical features of disease activity. And that's a kind of a tough recommendation. And it's not saying you shouldn't evaluate your patient. It's not saying that at all, but it is saying that clinically we aren't able to see as much as we really should be seeing in the management of our disease. Monitoring the disease, that was in terms of recommendation 6, we probably should be looking at these patients on a regular basis. And like I said, you know, the question came up earlier, how often is it? I will just raise one point. The average cost of an MRI is approximately $400 now, $450, the reimbursement for an extremity, including the radiologist. The average cost for any of the biologics on a monthly basis is running close to $1,000 per drug per patient per month. So even if you were going to be saying, I want to do an imaging measurement every 4 months, which may sound extreme, but regardless, the actual cost saving to do the right thing, to switch drugs, to stop drugs, or whatever it is far, far more exponentially beneficial by using imaging rather than arguing about the cost, which is what we have to deal with every day with our payers. Point number 8, the periodic evaluation of joint damage, usually by radiograph of the hand, should be considered. It's kind of too slow for what we're doing at the moment, so we all understand that the changes on X-ray don't happen fast enough, and that's where MRI and ultrasound are extremely valuable. Recommendation 9, if patients have neck involvement, most of us in this room are not capable of doing a neck X-ray and really seeing exactly what the pathology is. So for your patients with a cervical involvement, the recommendation is to do an MRI on that patient. And then finally, the 10th bullet, ultrasound and MRI can detect the inflammation that predicts subsequent joint damage, even when clinical remission is present. And that gets back to, once more, the original article that was referred to, Brown and Phil Conahan's article, and subsequently from Brigham, and a number of other articles where we are now very, very, very comfortable in understanding that there is a disconnect between clinical remission and structural remission. And if we are trying to do the right thing for our patients, and I'm trying to do it for them in my practice, then absolutely, it's not enough to just look at the patient feeling better, doing better, and having no evidence of active disease, because we see that the vast majority of these patients will continue to progress if we basically take our foot off the pedal or our eye off the ball. And I think what we really need to do is use our patients' clinical response as a guidance. And when they are in clinical remission, if we can in fact use imaging to help us measure what we should be doing with our drugs, truthfully, then possibly we could be able to start tapering back on our patients' medications and reducing their exposure to drugs that in their own way have significant adverse events. An interesting point is also when you kind of like wonder why there's this dissociation between clinical and structure. The question is it the disease, or is it what we are doing to the disease with our medications? Are our medications, the drugs that we're using, possibly kind of in some form or fashion, whether it's affecting the subchondral bone with bone edema, the synovium, but they're actually altering the way this disease is moving forward. And so we're seeing this kind of sort of imbalance between the way the patient is behaving and what we're actually seeing structurally. I put this slide up there only for one reason, because I know whenever I do give these talks, and I think this is a very educated audience, so this is not the standard audience that I unfortunately speak to, because it's much more preferable to speak to an audience like this. But nevertheless, this basically goes back to the article that Jimenez Boyer published when they actually did slices through the joint and looked at the comparison between an MRI, bone edema, and what the histology looked like. So we just need to understand that this is an inflammatory cell infiltrate in the subchondral bone. And if we think of it as inflammation, we then can really understand how we should be treating the patient. It's just that we can't always see this, and I think this is probably, for me, the most important guide that I utilize in practice. And if you look at some of the studies that are there and listed, and I'm not going to get into them, many studies are showing how bone edema is such an important prognosticator in terms of clinical outcomes, response to treatment, and ultimately functional disability, which, if bone edema is allowed to basically evolve into an erosion, is going to result into obviously a patient who is severely handicapped. And we spoke about the disconnect. So I think that what we see here in my particular practice is that I will basically use it to make a diagnosis. Even when I see the diagnosis as a parent, and you know, with a patient with a positive rheumatoid factor, positive CCP, multiple joints, you're not doing it for the diagnosis, but you're doing it to almost stage the patient, just like you'd stage the patient who has a lymphoma, so that you can follow that baseline as you move forward and change treatments, and you've got something to compare to as you go forward. And I just put this slide in It wasn't in my deck, it's not in your book, but I've used it before. And then when I heard Mikhail talking in particular, I just felt I'd like to throw that back in, because if you look at that slide and you kind of look at really what we're trying to do there, the goal is to try and get your patients into remission and then to reduce their drug, because that's the reason why you want them in remission. So if you use your clinical and your structural findings, that's going to give you a much better ability to taper down your drug and subsequently follow them. And if they start flaring up, maybe from a perspective of, in particular, bone edema, even if they haven't started flaring up yet clinically. So someone who's in remission could theoretically come back into your office every 6 months and be evaluated structurally through something like an MRI of their extremity, their most involved extremity, and that could determine whether you continue with a conservative or a more aggressive form of treatment. There's lots of publications that are using MRIs, outcome measures, and now Charles will talk about that, I'm sure, when he gets to his talk on clinical research. But the point being, this is where we are today. There shouldn't be any more debate on whether we use this or not. So I'll move on to some of the other conditions that we manage in the office on a daily basis. And osteoarthritis is obviously probably the most common condition that we see. And there again, bone edema shows up. So you can actually have a normal looking x-ray, but if you basically... Oh, okay, sorry. So you can have kind of a normal looking x-ray. So remember, in early osteoarthritis, you don't have to see any change in the joint space. You don't have to see osteophytes forming, but you may see that bone edema showing up again, which is telling you that there is something going on in that joint. So what kind of advice would you give to a patient then? It may be that you're not going to inject them with viscous supplements or whatever it is. Maybe you could put them onto some of the nutraceuticals, which may or may not be of some benefit, but certainly as a guide to their lifestyle, if they are a jogger and you start seeing bone marrow edema in someone's knee, you may not change what they do, because my experience is that you can change someone very easily. But regardless, you can start telling them that their weight-bearing exercise is going to result in something that's a little bit more serious than they may manifest at the moment. Remember, you're also going to see people coming with pain in their knee all day long, and it's not all osteoarthritis. You may basically have your classic meniscal tear. And what you do about your meniscal tear depends on whether you're an orthopedic surgeon hooked up to an arthroscopy tube, or whether you want to treat them conservatively. You know, there's a lot of information now in the literature that arthroscopic repair of menisci may accelerate osteoarthritis. So it's kind of interesting, but my point is really just to show you how imaging in the practice is absolutely of value to determine the different causes of pain in the knee. And we basically see we've basically got, you know, ACL tears, meniscus tears, very, very well represented by imaging. And ORC's basically consensus statement is that MRI changes of OA may occur in the absence of radiographic findings. And I think that's a critical understanding that we need to have. And it's like rheumatoid in many ways. We shouldn't be waiting for the osteophytes in the joint space to collapse before we start becoming more proactive in our treatment. MRI may add to the diagnosis of OA and should be incorporated in the criteria. Probably should be used for inclusion studies, and suddenly for some reason we're starting to see a lot more OA studies popping up in which MRI is something that is being used as an endpoint in some of them, not in all of them. And remember that other changes that you'll see on the MRI, and there's a whole host of them, are all causes of knee pain, but not necessarily managed in just blindly the way most times, unfortunately, especially in a primary care environment, take another NSAID and go on and go off. Obviously, I'm not going to talk about the value of MRI and ankylosing spondylitis. That would be a little redundant after we've heard, you know, everything Mikhail has had to say to us. But what I would like to say is, and I'm going to get into comparison between the large and small magnets, is that in my experience it is actually quite difficult to visualize the SI joints with a small magnet, especially if you've got a large patient. So I think we need to recognize what we can do and what we cannot do, and there are certainly I think many large magnets around. So for those particular patients, I do not manage them in the office. In terms of psoriatic arthritis, we've also heard all the reasons why it's of value. Diagnosis, monitoring, prediction of the disease course, and treatment response, kind of like, here we go, just like with RA, are all very, very appropriate in psoriatic arthritis. And we've also now got a new drug that's just been approved. We've got about 4 or 5 drugs now for psoriatic arthritis with the same questions that we have in rheumatoid arthritis. Which should we use and which should we not use? The question that has come up since I started in the very early days using a very small magnet, and now we've basically got, low field or small magnets that are really small by definition, and that they may be less than 1.5 Tesla, but they really are very, very capable. And there's advantages and disadvantages. I think in rheumatology, we need to recognize we're looking at the musculoskeletal system. We're not looking at the brain. We're not looking at the spinal cord. So in many cases, the low field, other than maybe 1 or 2 examples like I just mentioned with the SI joint, is more than sufficient to be able to help us make a diagnosis in a very comfortable environment. It's much easier for me to get the patient into a sort of small MRI in my office, which is open, which can do the whole spine, but nevertheless, I don't have to send them out, wait for 3 weeks, and so on and so forth. And it's certainly much more cost effective, and definitely the patient much prefers it than going to a diagnostic center where you don't have control of the radiologist, by the way. And that's one of the things I should mention. When you're doing in-office MRI, most of us are not reading it. I am the last person to tell you that I want to be reading my MRIs. But we have a board-certified musculoskeletal radiologist who gives us a 24-hour turnaround, who actually will do even better than that. If I say to him, I've got a patient in my office now, Steve, please, can you just look at this MRI that's being done right this moment? I can get that instant result. And that is so huge compared to sending someone to a diagnostic center where I have no control. I get back a report saying no evidence of fracture, osteoarthritis noted, or something ridiculous that has no relevance to why I ordered the MRI in the first place. We see that for, this is a study that was done actually quite a long time ago in 2004, comparing a 0.2 Tesla to a 1.5 Tesla, and they were pretty much diagnostically equivalent for what we basically want to do there. And now the low field capabilities, and it depends on which machine you're using, but for example, the one that I've got in my office, which is a 0.3 Tesla, can do the axial skeleton, shoulders, hips, knees, feet, ankles. So pretty much as I need to do for most of my patients. And that, I think just as an example of how you can pretty much assess labral tears, full thickness tendon tears, and so on. But there are limitations. The size of the patient is important. Some of them can't fit into the magnet, and there is a limitation to the field of view. So one needs to be honest, and I think choose the right patients, and then, obviously for those patients who just, for whatever reason, would be better off using a large magnet, that's what you basically need to do. Just very quickly, this is like comic book time, just looking at some of the things that you can see. This is a patient with a pigmented villonodular synovitis, and there we see that very nicely there. Bone injuries, osteonecrosis is something that you'll see in patients, especially who have had trauma, and they've now basically got a bit of necrotic bone over there, a significant, serious problem. You need to really make that diagnosis, and all the listed things over there, contusions, fractures, etc., are all obviously well seen. And even though we're rheumatologists, we tend to see these patients coming in who may have had some traumatic issue fallen down, especially some of the older patients who basically have gait problems, and so this becomes a very important diagnostic tool. In our office, we have a foot and ankle physician, podiatrist, and I mean, it's quite amazing how you will miss stress fractures on regular x-ray, and yet you will basically see those fractures on MRI, and that's something that is just a very simple, important diagnosis. Recalcitrant heel pain, plantar fasciitis, common diagnosis, and that gets back to the talks yesterday of PRP injections for plantar fascia, how you manage these conditions. They all kind of dovetail. So everything that we're hearing is that really the rheumatologist should be the musculoskeletal manager of whether it's pain, whether it's inflammatory, whatever it is, and the imaging tool that you're using is very, very important. And here we see someone who's got a torn flexor digitorum tendon, And the importance of this is not to keep re-injecting that tendon. The patient comes in, has got what you think is tendonitis. You do one injection, you do 2 injections, they're not responding. Well, guess why? Because they've got a tear of their tendon, osteonecrosis of the wrist that you see over there. Kybox disease could be something seen in children or in adults, but certainly avascular necrosis. They've had a fracture of the scaphoid bone. An MRI is a very important tool that you can use in your office. Epicondylitis, I mean, there you see it loud and clear and very obvious. Once more, getting back into that example of, whether you want to inject the patient, immobilize the patient, use PRP, but certainly imaging can help see not only the diagnosis, but can help you follow up and see whether that inflammation that was present is gone. I actually personally last year had surgery in my elbow because I tore my medial ligament in my elbow playing golf the way I play golf, which is not very well, but bottom line is that the MRI was able to show that, and rather than just keep repeating injecting it, I knew what I needed to do, which was to go in and have it repaired. Bursitis, looking at the crystals, the fluids, these things are all just, no-brainers. The rotator cuff tears, very, very good with both ultrasound and MRI. Sometimes anatomically you want to maybe isolate it a little bit more precisely with the MRI. I think, the ultrasound is more real-time. The MRI does take a little while longer, but these are the benefits that you get diagnostically from a bunch of different conditions. Certainly avascular necrosis, you may have a totally normal hip x-ray, and then when you do the MRI, you see that really crescent sign and that area of avascular necrosis, which is a very important diagnosis for our patients with lupus on steroids, sickle cell disease, or whatever the case may be, to be able to use the MRI. So the final slide on what the MRI brings to my office is all the different pathologies in the neck that the MRI is capable of doing, and we haven't thrown in the spinal stenosis and the facet joint arthritis and so on. So I think the point of what really we're trying to say is that in my office, the low-field MRI is proficient at assessing a wide spectrum of non-inflammatory conditions, non-arthritis-related pathology, but which we encounter on a daily basis and which is extremely important. There's in your handouts a reimbursement issue numbers. When I submitted the slides, Oren kind of immediately sent back to me and said our numbers are different. The point being is that they vary from state to state. They're changing all the time. This is just meant it's a guideline. It's not meant to be anything that you should basically hang your hat on. I think if you really are thinking of doing MRI in your office, you've got to look at who's going to basically utilize it. You've got to look at the costs of setting it up. And by the way, the handout that was available to you from the seminars, just make sure you get a copy of that reprint, because I think it's really a very, very good article that will tell you everything you want to know about using MRI in the office. And I think, we've just got to basically recognize if we really want to help our patients in any form of musculoskeletal disease, we should make it easier for them to have access to the best diagnostic capabilities, both MRI and ultrasound, to allow us to make the best treatment choices for them. Thank you very much.